Hello, I'm Iftikhar Kalu, a professor of medicine at the Department of Cardiovascular Medicine, Mayo Clinic, Rochester, Minnesota, and I'm pleased to have this opportunity to present an overview of genetic testing for coronary heart disease. Coronary heart disease is common, it's heritable, it's morbid, and yet it's preventable. The prevalence is 6.7% in US adults greater than 20 years of age, and every 40 seconds an American will have a heart attack. We assess risk of coronary heart disease using factors identified by the Framingham Heart Study more than 60 years ago. And thus far, we are pretty much using the same equations, and no single biomarker has made it into the risk calculator, although CRP and lipoprotein A are mentioned in guidelines for use in certain settings. Many individuals that have a cardiovascular event will not have been deemed to be high risk if they had undergone a risk profiling using current risk equations. This is an example of a patient of mine who had a heart attack and needed coronary artery bypass grafting at age 41. So risk prediction is suboptimal. Now, can genetic testing help us improve risk stratification? Well, a simple tool is family history. We know that heritable factors influence susceptibility to coronary heart disease. In this study of twins in a Swedish registry, if one of the monozygotic twins had CHD, the risk for the other twin was 8 to 15-fold higher. And in dizygotic twins, it was 2.6 to 3.8-fold higher. If a sibling has a history of coronary heart disease at an early onset, then the risk of disease in the other siblings is nearly double. Now, we have in recent years gone beyond family history to actually measuring genetic variation associated with susceptibility to CHD. And this was done through what's known as genome-wide association studies, where we take large numbers of cases and controls, we measure 500,000 SNPs in both groups, and then we simply see which SNPs vary in frequency in the two groups. And these results are typically plotted in what's called a Manhattan plot, and these are various chromosomes lined up on the x-axis, and then the significant variants are shown on the y-axis. And of course, the strongest signal is located on the 9p21 locus and is present in nearly half the population and increases the risk by about 50%. Now, to date, more than 160 loci that influence susceptibility to CHD have been discovered. And we can use this information to actually profile each individual depending on the number of risk alleles at each of these loci. So these can vary from 0, 1, or 2. And if we count them at each risk locus, we can arrive at a polygenic risk score, here shown as simply a count of the risk alleles, and on the right side shown as a weighted sum of the risk alleles, where the weight is the strength of association of the SNP with coronary heart disease. Now, you can imagine that even though this is a normally distributed curve, individuals that are at the tails of the distribution are likely at significantly higher risk and could be identified by polygenic risk scores. More recently, the field has moved on from looking at specific variants that meet a particular significance threshold to actually incorporating millions of SNPs across the genome. And these so-called genome-wide polygenic risk scores appear to be more strongly associated with coronary heart disease. You can see that in this group of polygenic risk scores using limited variants, the odds ratios were about 1.38, but when genome-wide polygenic risk scores were used, the odds ratios were significantly higher, as was the area under the curve. Now, if we take the top 5 percentile of individuals in a genome-wide polygenic risk score, the odds ratios for coronary heart disease are more than 3-fold higher. And if we take the top percentile, then the odds ratios are nearly 5. And this is equivalent to the risk from a monogenic condition, familial hypercholesterolemia. In this study of 2,081 patients with premature MI and 3,761 controls, monogenic FH was present in 1.7%, and the LDL obviously was high at 206 on average, and the odds ratios were 3.8. if we check the polygenic risk score distribution, those in the top 5th percentile, the prevalence was 17%, tenfold higher. And the LDL was nondescript. It was average LDL of 132, but the odds ratios were similar. So these individuals would not have been identified unless polygenic risk scores were estimated because the LDL was not high. So in the UK Biobank, which incorporates more than 480,000 individuals, this study showed that a polygenic risk score, a genome-wide polygenic risk score for coronary heart disease, was actually stronger than conventional risk factors such as cholesterol, hypertension, diabetes, and smoking. And that when combined with conventional risk scores, the discriminant property of the combined risk score was significantly higher than a risk estimated based just on conventional risk factors. A huge advantage of polygenic risk scores is that they're not strongly correlated with existing risk equations. In one study, the correlation between polygenic risk score and the pooled cohort equations was quite modest at R equals 0.015. Surprisingly, the correlation between PRS and family history is also quite modest, and therefore we can incorporate PRS into existing risk equations. Here's an example. This is a 47-year-old male whose pooled cohort equation estimated CHD risk at 10 years is 7%. When we do a polygenic risk score for CHD, his odds ratio is estimated at 1.42, and because the two are not correlated, we can simply use them in an additive fashion, and the resulting estimate now approximates more than 10%, 10-year risk, and this person could be a candidate for statin therapy. Now, polygenic risk scores are not deterministic. We can reduce polygenic risk not only by lifestyle changes, but also by statin therapy. And there are retrospective studies that have shown that incorporating a favorable lifestyle is associated with reduced CHD risk in those with high polygenic risk. And similarly, in both the primary and secondary prevention settings, statin therapy reduces CHD risk in those with high polygenic risk scores. We conducted a randomized control study in more than 200 individuals who did not have CHD but were at intermediate risk. And we gave one group combined risk score, which incorporated both the conventional risk factors as well as a polygenic risk score. And the other group just got the Framingham risk score. We hypothesized that individuals that would get the combined risk score would have lower LDL cholesterol at 6 months. And indeed, it turned out to be the case. And you can see here that the LDL cholesterol at 6 months was lower in individuals that got the polygenic risk score. And this was actually all due to individuals that had the high polygenic risk score compared to those that had the low polygenic risk score compared to those who just received the Framingham risk score. And this was almost entirely driven by the fact that individuals that had higher genetic risk were more often initiated on statin by the primary care provider after learning of the composite risk estimates. So this study shows that we can use polygenic risk scores in the clinical setting to make decisions about statin initiation. One limitation of the currently available polygenic risk scores is that we don't know how well they apply to minority groups. In this study from our lab, we found that a polygenic risk score was quite strongly associated with CHD in European Americans, but in African Americans, the strength of association was nearly halved. So a great need in this field is to develop robust polygenic risk scores for other ancestry groups. I think as we go into the future, we are likely to see an evolution of risk prediction models using more and more data. And one can imagine a scenario where we use pooled cohort equations, but add polygenic risk scores, family history, data from environment, physical activity, and other environmental measures, omics data such as metabolomics, and arrive at a risk estimate that's more refined than simply one based on pooled cohort equations. So to summarize, coronary heart disease is heritable, and ascertaining family history is quite important. Polygenic risk scores, however, provide a measure of genetic predisposition to coronary heart disease independent of family history. In the MyGene study, disclosing a polygenic risk score for coronary heart disease had clinical utility in lowering LDL cholesterol levels in intermediate risk patients, and polygenic risk scores could potentially be used in the clinic for refining risk estimates. Thank you for your attention, and I'd be happy to answer any questions that are directed to me at the email listed here.